Good day, everyone, and thank you for joining us in this pediatric track of the Arab Thyroid Congress today. It's a pleasure for me to be the chair of this session. We have today three of our outstanding speakers that will talk to us today about thyroid issues in pediatrics. First, we'll start with Dr. Rasha Hamza, the head of Pediatric Endocrinology and Obesity Unit at the Faculty of Medicine, Ain Shams University in Cairo, Egypt. She's also the chair of the European Society of Pediatric Endocrinology Education and Training Committee since 2019. And she's the vice president of the Arab Society of Pediatric Endocrinology and Diabetes. And she serves as well as a member in the advisory board of the American Association of Clinical Endocrinology. And she will be talking about ectopic thyroid in pediatrics. Our second speaker is Professor Stephen Wagesbach. He's a professor at the Department of Endocrine, Neoplasia, and Hormonal Disorders, Division of Internal Medicine, the University of Texas MD Anderson Cancer Center in Houston, Texas. Also, he's a professor at the Department of Pediatrics, Patient Care, Division of Pediatrics, the University of Texas MD Anderson Cancer Center in Houston as well, and an adjunct professor at the Department of Pediatrics, Division of Pediatric Endocrinology in Houston, Texas. And he will be talking to us today about updates in the management of papillary thyroid carcinoma in pediatrics. And last, Dr. Qabalan will be talking to us about Graves' disease in pediatrics. Dr. Qabalan is a consultant pediatric endocrinologist and the chairman of the Department of Pediatrics at Tawam Hospital and adjunct associate professor at the United Arab Emirates University in Al Ain. He previously held the position of interim chief medical officer and acting chief quality officer at Tawam Hospital and assistant professor of pediatric endocrinology and metabolism at the Baylor College of Medicine in Texas, Houston. It's a pleasure to have you all today, and the floor is all yours.
First, I'd like to thank Dr. Nasser El-Juhani for inviting me to participate to the first meeting of the Arab Thyroid Association. It's a great pleasure to be with you today. And since this is a pediatric session, I'm going to speak about part of the congenital hypothyroidism, and this is ectopic thyroid. And I'm going to show you that it's not always easy. And let me open the scene by this interesting photo. And this is a newborn with ectopic lingual thyroid gland. When facing a neonate like this, we as pediatric endocrinologists have a lot of questions that pop to our mind. First, is it ectopic thyroid, or could it be any other swelling? Which genes are incriminated? Could there be other functioning thyroid tissue? What are the complications? What is or are the most important diagnostic tools? And finally, and most important, is it surgery or medical treatment or no treatment, and we will just follow up? We all know that the thyroid gland develops in the 3rd week gestation as a diverticulum between the first and second pharyngeal pouches. It appears as a midline endodermal diverticulum in the floor of the pharynx at the base of the tongue, and this is the foramen cecum. And then it elongates to form thyroglossal duct and descends in front of the hyoid bone and laryngeal cartilage. And then it reaches the final position at the 7th week gestation. And finally, it ends by dividing into 2 lobes, right and left thyroid lobes. And the descent of the thyroid gland could be arrested at any of these points. Ectopic thyroid is the most frequent form of thyroid dysgenesis. In 70 to 90%, it is the only thyroid tissue present. As other thyroid disorders, it's 4 to 7 times more common in females than males. And so, ectopic thyroid gland is the presence of thyroid tissue in locations other than the normal anterior neck region in front of trachea, between the second and fourth tracheal cartilages. It can occur anywhere along the path of its descent, all through the pathway of its descent. Now, taking a closer look at the sites of ectopic thyroid tissue, here you can see the normal position of thyroid gland, and this is the eutopic thyroid. Ectopic thyroid could be lingual thyroid, and this is the most common. This is 90%. Intralingual or sublingual, pre or sublaryngeal. It could occur inside a thyroglosal cyst, intratracheal or esophageal, mediastinal, and this is a very long list of other places where ectopic thyroid could occur. So ectopic thyroid gland could be present in any site in the body. It could be dual or triple ectopic thyroids. And here you can see transcription factor gene mutations resulting in thyroid dysgenesis. And you can see here that those responsible for thyroid ectopy are the FOXE1 gene and NKX25 gene. Also, transcription factor gene mutations have other associated clinical findings in addition to thyroid finding. For example, with the FOXE1 gene, this is the Bamforth-Lazarus syndrome, and I'm going to show you how it looks like. The NKX25, the thyroid is associated with cardiac malformation. NKX21 associated with respiratory distress, ataxia, and chorea. PAX8, renal and urethral malformation, and finally TTF2, guanylotresia, cleft palate, and spiky hair. So the message here is that it's very important to look for associated clinical findings and or congenital malformations in patients with congenital hypothyroidism, because as you've seen, some mutations are associated with other malformations or anomalies in addition to thyroid gland. And this is the Bamforth-Lazarus syndrome, which is of autosomal recessive inheritance due to loss of function missense mutation of the FOXE1 gene, thyroid transcription factor 2. Newborns present with thyroid dysgenesis, mostly athyreosis, but could be ectopic, presenting with congenital hypothyroidism, and all of them have cleft palate and spiky hair. And some of them have guanylotresia and bifid epiglottis. We identified a new homozygous FOXE1 missense mutation responsible for enhanced activity of thyroglobulin and TPO genes in an Egyptian boy whose phenotype is similar to that reported previously in patients with loss of function FOXE1 mutation, presenting with athyreosis, cleft palate, and partial guanyl atresia. And this is a novel mutation that was not described before, and we published the case of this boy in Thyroid Journal. Ectopic thyroid could present at any age. Mostly it's identified in the neonatal period via newborn screening. Some cases are delayed up to the 4th or 6th decade when ectopic tissue transforms to abnormal tissue pathology and presents with symptomatic manifestations. And in other cases, ectopic thyroid enlarges during periods of stress like puberty, pregnancy, and then it could be identified by imaging. Lingual thyroid is usually asymptomatic in 47% of cases, but sometimes there are local pressure symptoms like dysphagia, dysphonia, sleep apnea, snoring, dyspnea, upper airway obstruction. And with regard to the thyroid function, commonly it presents with hypothyroidism, and very rare it could present with hyperthyroidism. Physical examination of the thyroid is not sensitive for identifying the cause of congenital hypothyroidism, and the ectopic thyroid could be missed during examination, even by expert endocrinologists. And that's why radiology supported by lab is very important in its diagnosis. And you can see that there is a various spectrum and severity of thyroid ectopia, And in this table, you can see that according to the various sites of thyroid ectopia, there is variable symptomatology, age of diagnosis, and thyroid status. So it's totally variable in its place, symptoms, age, and thyroid function. Sometimes ectopic thyroid can present with complications, and the most common is complications of untreated hypothyroidism. Sometimes it could present with pressure symptoms, and I'm going to show you cases like this, or could present with benign neoplasm and thyroiditis. This is quite infrequent and very rare, less than 1%. There could be the risk of papillary carcinoma on top. And even more, sometimes it could be accidentally discovered. And this is a common presentation during neonatal screening program. And in this slide, I'm going to share with you the ASPE consensus guidelines. And these are the guidelines proposed by European Society for Pediatric Endocrinology on the diagnosis and management of congenital hypothyroidism, laying stress on ectopic thyroid. If the TSH by screening is equal to or more than 40, start treatment and do imaging. If less than 40, confirm by venous sample of thyroid function test. If the free T4 is below the normal or TSH above 20, even with normal T4, again, you have to start treatment and do imaging. What about the gray zone? When the TSH is from 6 to 20, retest after 2 weeks and do imaging, but you can wait on the treatment. It's important to do thyroid ultrasound, and sometimes we do a CT or MRI in very selective cases. And remember that thyroid scan is mandatory if the thyroid gland is not visualized by ultrasound to exclude ectopia, because this is the only way to differentiate ectopia from thyroid aplasia. And so the diagnosis of thyroid ectopia rests mainly on radiology, thyroid scan, thyroid ultrasound, CT or MRI in selective cases, and the radiology is supported by lab thyroid function as well in the form of free T4 and TSH. So the role of radiology is very important in diagnosing thyroid ectopia. Thyroid scan plays the most important role in diagnosing ectopy and differentiating it from other neck masses, while ultrasound is important in cystic lesions like thyroglossal cyst. CT and MRI are valuable in identifying the site of ectopy, especially when away from the pathway of the normal thyroid and if there is suspicious malignant mass. Another important point is to differentiate between ectopy of the thyroid and other neck masses. And here you can see lists of neck masses, whether congenital, inflammatory, or neoplastic, that need to be excluded as well. And that's why thyroid scan is mandatory. Thyroglossal cyst is an ectodermal remnant along the course of the thyroglossal duct. And it's very important to be differentiated from other neck masses and ectopy of the thyroid. It's usually asymptomatic midline cystic swelling, which moves with swallowing and tongue protrusion. The main treatment is surgical excision because infection is inevitable. Moreover, 1% could develop papillary thyroid carcinoma on top. Thyroid ectopia could occur inside a thyroglossal cyst, and here ultrasound confirms the diagnosis. And therefore, it's very important to perform thyroid scan to look for eutopic thyroid and to exclude thyroid ectopia inside the thyroglossal cyst or in any other additional site. Could it be a cleft branchial cyst, another neck swelling that should be differentiated from ectopia? The branchial cyst occurs due to failure of obliteration of the second branchial cleft. It presents in the late childhood or young adult as a soft, fluctuant, painless swelling deep to the upper 1/3 of the sternomastoid anteriorly. It can present with some pressure symptoms, infection, or fistula. And here, ultrasound is diagnostic. And the treatment is surgical excision plus antibiotics if infected. A puzzling part is the management. When managing ectopic thyroid, there are different ways to go through. A very difficult question that we need to answer. Which way shall we go? And the answer here differs according to the site, symptoms, and thyroid function. The first question here, shall we treat or wait? And if we decide to treat, is it medical or surgical? The management of ectopic thyroid differs, as we said, according to the site, pressure symptoms, thyroid function. If the case is asymptomatic and euthyroid, no treatment, just follow-up. If the case presents with congenital hypothyroidism, you have to start lifelong thyroxine and follow-up. If there are tolerable pressure symptoms, give suppressive doses of thyroxine. And it's very important to note to avoid unnecessary surgery, to avoid permanent hypothyroidism, because lingual thyroid may be the only functioning thyroid tissue in 70% of cases. So please don't rush to surgery. And I'm going to show you a case that was rushed to surgery, but was saved in the last moment. So before excision, one must be sure of the presence of a normal thyroid tissue in the neck or elsewhere. So what are the indications of surgical excision of an ectopic thyroid? If there is airway obstruction, malignancy, bleeding or ulceration, uncontrolled hyperthyroidism, or intracardiac thyroid ectopia. And now I'm going to share with you a variety of real-life case scenarios of ectopic thyroid stories. And these are cases from my patients that I'm going to share with you, and I really learned a lot from these cases. This is a 14-year-old girl who presented with a midline swelling at the base of the tongue. As you see, since 8 months, it was gradually increasing in size. She developed mild dysphagia, fatigue, weight gain, secondary amenorrhea. There is no bleeding or ulceration. And the thyroid gland was not palpable in its normal site in the neck. The thyroid functions revealed high TSH, low T4, and the antibodies were negative. So she has clinical hypothyroidism. The ultrasound revealed normally located thyroid gland, but it was very small, severe hypoplasia. And the scan revealed 2 foci of intense uptake, one at the base of the tongue and submental region, and a weak uptake in the thyroid bed. So you can see 3 thyroids in this case. So this is a dual ectopic thyroid gland in addition to the eutopic hypoplastic thyroid gland. So this is the diagnosis. Now, what is the suggested management of such a case? Of course, surgical removal of the sublingual thyroid because it's causing pressure symptoms. And of course, the girl has to start thyroxine therapy because she has clinical hypothyroidism. Another unique story that I want to share with you teaches us to think twice before referring the patient to surgery. This is a 6-year-old girl who came with a midline neck swelling. It was asymptomatic, but this was a firm, painless swelling which moves with deglutition. No pressure symptoms, and the girl was planned for surgical resection. She was prepared for surgery. The thyroid was not palpable in its normal site. The thyroid functions are normal. Antibodies are negative. A surgeon suggested pediatric endocrinology consultation before doing the operation. So this came actually by chance. This was a very lucky girl. The ultrasound revealed a midline neck mass and thyroid gland was not seen in place. Now, look what we found in the thyroid scan. Ectopic thyroid in the suprahyoid and hyoid level and at the base of the tongue, 3 ectopic thyroids. And preoperative thyroid scan diagnosed a triple ectopic thyroid, and this was the only functioning thyroid tissue. And luckily, it was not causing any pressure symptoms to the girl. So remember that thyroid scan and ultrasound must be done as a routine workup in neck swellings, preoperatively to avoid unnecessary surgery and lifelong thyroxine therapy. So what is the suggested management here? Just follow up, and the surgery was cancelled because the girl does not have any symptoms and she doesn't have any pressure, and just follow up. If there are any pressure symptoms, surgery will be needed. And don't forget to look for the uncommon. Yes, common is common, but don't forget to look for the uncommon. Like this 10-year-old girl who came with a midline neck swelling, noted at the age of 2 years, gradually increasing in size. It was soft, cystic, and not tender. It moves with swallowing and tongue protrusion. No pain, discharge, or lymphadenopathy. And again, the girl is asymptomatic. The TSH was found to be high, T3 and T4 normal. The antibodies are negative. So she has subclinical hypothyroidism. And the ultrasound revealed a thyroglossal cyst, multiseptated anechoic lesion in the midline of the neck. And the thyroid gland was not visualized in the thyroid fossa in the neck. Now, the thyroid scan was another surprise. There was ectopic thyroid anterior to the hyoid and inside the thyroglossal cyst. But there was absent uptake in the normal thyroid bed. So the only thyroid tissue was in hyoid and inside the thyroglossal cyst. And the CT scan confirmed the previous finding. And in fact, the CT scan was done here because there is a risk of carcinoma in approximately 1% of thyroglossal cyst containing ectopic thyroid tissue. So we have a case of ectopic thyroid gland inside a thyroglossal cyst and infrahyoid. What do you think? What is the suggested management? Ideally, surgical excision of the thyroglossal cyst and tract because it could turn malignant and infection could occur on top, while the infrahyoid will be left. And the girl will need thyroxine if developing frank hypothyroidism in the future. And she has already hypothyroidism, so we have to start thyroxine treatment. Sometimes an unusual clue could be the clue for diagnosis. Like this 18-year-old girl who presented with abdominal pain, not responding to painkillers, no lymphadenopathy or organomegaly. The ultrasound abdomen revealed a retroperitoneal hypoechoic mass with no lymph node enlargement. And the CT described a well-defined pancreatic mass with some calcification and cystic degeneration. So pancreatic tumor was suspected and surgical resection of the mass and the biopsy were done. The surprise was that the biopsy revealed thyroid tissue, no malignant cells. So this was an ectopic thyroid tissue, pancreatic ectopic thyroid. And it was confirmed by immune reactivity and it was of benign nature. Routine labs, fasting blood sugar, amylase, lipase, thyroid functions, and antibodies were normal. And the thyroid ultrasound revealed normal appearance and location of thyroid. So there is a normal thyroid in location in addition to the ectopic pancreatic thyroid. So the scan confirmed the normal uptake in the thyroid bed and there wasn't any other ectopic thyroid tissue. So the diagnosis here is a very rare situation, ectopic pancreatic thyroid with a normal functioning utopic thyroid. And the girl remained asymptomatic with normal thyroid function after removing the ectopic pancreatic tissue. So what is the next step? No further step. We just need to follow up the thyroid function to make sure that she won't develop hypothyroidism. And the girl is doing very well till now. And sometimes stories have a happy ending, like this unusual case of 16-year-old boy who presented with chest problems. When examining the boy, he had a swelling at the base of the tongue since 5 years. It was asymptomatic. And then he developed dyspnea, cough, chest pain since 2 weeks. And it's not responding to usual lines of therapy. A CT chest was done and it revealed large anterior mediastinal mass as you see in this photo. ECG and echo were normal, pulmonary functions are normal, thyroid functions and antibodies were normal, and the cardiac enzymes were normal as well. We needed to exclude the cause of the chest pain. Thoracoscopy and surgical resection of the mediastinal mass was done. Again, another unusual, unexpected surprise. The biopsy revealed thyroid tissue. So this is an ectopic sublingual in addition to anterior mediastinal thyroid, which was the cause of the chest pain and pressure symptom. And the neck ultrasound revealed normally placed thyroid gland. The scan revealed the sublingual ectopic thyroid, anterior mediastinal ectopic thyroid that was removed by thoracoscopy, and the normal utopic thyroid, another triple ectopic thyroids in 3 different locations. A very unusual coincidence in that case. And the boy remained asymptomatic with normal thyroid function after removing the mediastinal mass. And the question here, what is the next step? Again, follow-up, because after removal of the mediastinal mass, the boy is doing very well. We are following up his thyroid function. He is fine. He doesn't have any symptoms of hypothyroidism. The labs are fine and no other pressure symptoms. So these were some of the stories from the gallery of ectopic thyroids from the children that I have. And I'm sure every one of you has got a lot of other stories about ectopic thyroid to tell. So finally, don't forget that ectopic thyroid is not always easy, as you've seen. Sometimes it's not straightforward. And I think it's very important to follow a stepwise approach in order not to miss a case of ectopic thyroid. Because as you've seen, sometimes the presentation is very odd, especially in children and adolescents. And this is how it feels when managing a case of ectopic thyroid. Every step counts. It counts a lot in diagnosing ectopic thyroid, in identifying the site of ectopic thyroid, in deciding on the management, whether you will treat or not, whether you will go for surgery or medical treatment or follow-up. So this is really, really important. Every step counts when dealing with a child with ectopic thyroid. Because as you see here, if the right decision is not taken, it's as if the child is falling from a very high place down. It's very risky. It could be risky. It could have complications. It could turn malignant. So we need to diagnose and treat correctly. So my final conclusions are thyroid ectopia is rare, but it's the most common cause of thyroid dysgenesis. Look for it. It has a variable age of presentation, as you've seen, and clinical manifestations are variable, and sometimes it could be asymptomatic and accidentally discovered. Don't forget to exclude ectopic thyroid in any patient with dysphagia, unexplained respiratory symptoms, or subclinical hypothyroidism. Thyroid scan and ultrasound are mandatory in the diagnosis of thyroid ectopia and as a routine workup for neck swellings. Radiology is very important to reach the final diagnosis, supporting the labs, of course. And finally, it's very crucial to look for other functioning thyroid tissue before considering surgical removal of ectopic thyroid to avoid unnecessary lifelong thyroxine. And finally, I'll end up with this very nice quote for Albert Einstein. I like this quote. Thinking is hard work. That's why you do it. So ectopic thyroid is rare, but it's there. Think of ectopic thyroid. Don't take congenital hypothyroidism easy. We have to follow it. We have to go after it. If you cannot see the thyroid gland by ultrasound, do a thyroid scan, look for the thyroid, find it, and treat correctly. Thank you very much for your attention.
Thank you very much. Thank you very much, Dr. Rasha. And it was very nice, really. You talked about something which is uncommon, but again, it's very important to recognize and again, to manage. I think now it's time to go for our second speaker. Second speaker is Professor Stephen Wiggisberg. He's a professor at Department of Endocrine, Neoplasia and Hormone Disorders, Division of Internal Medicine, University of Texas, MD Anderson Cancer Center at Houston, Texas. And again, he had been adjunct professor at Department of Pediatric Patient Care, Division of Pediatric, University of Texas, MD Anderson Cancer Center, Houston, Texas. And again, he's an adjunct professor at Department of Pediatric, Division of Pediatric Endocrinology, University of Texas, John and Catherine McGovern Medical School at Houston, Texas. Our Professor Stephen, he's well-known figure when we talk about carcinoma and pediatric. He had been an active researcher. He has got more than 150 publications in a peer-reviewed journal. Again, he had been supervising and teaching many of colleagues who had been graduated under his supervision. Again, he has participated in many scientific work, and he had been peer-reviewed in many medical journals. I think to summarize 45 pages of CV is always a difficult task, but I think the talk that we are going to hear today in the update in management of papillary thyroid carcinoma in children is worth listening. And I think we are very much eager to hear from you, Professor Stephen, on what is the update on the management of papillary thyroid carcinoma in children. So please, the floor is yours.
My name is Stephen Wiggisberg from the University of Texas MD Anderson Cancer Center in Houston. And it is my privilege today to talk to you about an update on the management of papillary thyroid carcinoma in children. I'm very honored to have been asked by the meeting organizers to give this presentation at the first annual Arab Thyroid Association Congress. So thank you very much for this opportunity. I do have one relevant financial relationship to disclose with Bayer. What I'd like to do over the next 20 minutes is to give you an overview of pediatric papillary thyroid carcinoma management in the context of current guidelines, which I'm labeling as the past. I'd like to tell you how we're currently thinking about the role of surgery and radioactive iodine in the treatment of this disease, our so-called present treatment. And then I'd like to summarize current and future treatment options, particularly for patients with advanced disease or thinking beyond radioactive iodine in the treatment of advanced disease. And so we'll kind of get a glimpse into what the future of treatment may look like. I'd like to first start with some background and details about diagnosis. As you guys know, pediatric papillary thyroid carcinoma is the predominant histology that's seen in pediatric thyroid cancers. So over 90% of childhood thyroid cancers will be papillary thyroid carcinoma. You can see here the overall incidence of papillary carcinoma in children. The most common age affected is the teenagers, ages 15 to 19. And you can see here that there is a female to male predilection, particularly at the older ages, that's not seen at the youngest ages. Similar to adults, there is data that the incidence of pediatric PTC has been rising over the last couple of decades. I'd like to just give an overview of how pediatric papillary thyroid carcinoma differs from what we typically see in adults. As I mentioned before, PTC is the predominant histologic subtype. We would rarely see poorly differentiated or frankly anaplastic tumors. PTC also predominates in adults, but we would be more likely to see more aggressive histologies in that population. Children have a high rate of lymph node and lung metastases compared with adults. Fusions involving the genes in TRAC1 and TRAC3 and RET predominate in pediatric PTC, where adult PTC, we tend to find more BRAF point mutations. In children, we see more iodine avid disease. In adults, we see less of that. But we're coming to recognize actually that children with papillary carcinoma may have more RAI refractory disease than was once appreciated. Despite advanced disease presentations with a higher incidence of distant disease in children, children actually have an excellent long-term prognosis, so very different from the adult patient being diagnosed with a similar extent of disease. So over the next few slides, I'd like to just go through some of the data behind these differences. So as I mentioned earlier, lymph node disease is much more common in children. In some series, you'll see up to 80% of children with PTC have lymph node disease, so it is very, very common. There is a higher risk of lung disease in children. Depending on the series, you'll see anywhere between 10 to 25% of children having been diagnosed with stage 2 or distantly metastatic disease. The main risk factor for that is the child presenting like this with bulky cervical lymph node disease. Those are the patients who are at the highest risk for distant metastases. Now, very rarely we can see bone metastasis as well as metastases to other solid organs as demonstrated in this thyroid scan. And very rarely do we see disease that has metastasized to the brain. When looking at survival, again, long-term outcomes are excellent, which underscores the importance of having this discussion with our patients' parents when we first meet them, telling them that their child will do well, even though they've just been diagnosed with cancer. Just wanted to share some data from these two studies. This is a study using SEER data. Basically, at 30 years of after diagnosis, disease-specific survival is 99% in children. So all comers, long-term survival is the norm. This is data from MD Anderson here on the right that specifically pulls out 144 patients with papillary thyroid carcinoma with stage 2 disease. So these are distantly metastatic patients diagnosed either during childhood or later in adulthood. And you can see here that the median disease-specific survival is 53 years. So very, very good long-term outcomes. And if we look at this 30-year time point, you can see that even with distant disease, 93% of patients are still alive. And I was happy to see this actually coincided very well with the SEER data. This line represents those with distantly metastatic disease. Now, in contrast, we see more of a median disease-specific survival of about 5 years in adults diagnosed with lung metastases. With our better understanding of the molecular underpinnings of papillary thyroid carcinoma, there's been more recent studies that have looked at this, and it's a very exciting time that we're learning more about the biology of this disease. So just to highlight two more recent studies, on the left here, this is the Korean study that nicely showed that, again, fusion genes predominate in children, but even so more in the youngest children. So the youngest children with papillary carcinoma are the most likely to have a gene fusion, either in RET or in TRAC1 or in TRAC3. And this was a recent study from CHOP looking at a large cohort of pediatric PTC patients, and you can kind of see here this oncoplot. And the take-home messages from these studies is that fusion-positive tumors are seen with a younger age of diagnosis. An important finding is that these tumors tend to have a single oncologic driver. They don't tend to coexist with other molecular alterations, which probably is what leads, partly what leads to a better prognosis compared with older adults that may have concomitant mutations that can impact the disease aggressiveness. And as an example, and I think Dr. Al-Azharani was one of the first to show this, looking at TERT promoter mutations, very, very rare in children, whereas we tend to see those more commonly in adults, particularly coexisting with BRAF mutations. The CHOP study also suggests, as well as some others, would suggest that the fusion-positive tumors are associated with more invasive behavior, meaning more lateral neck lymph nodes and more lung metastases. So now it all kind of makes sense, right? Younger people have these fusions. These fusions tend to be associated more with advanced disease. And so that likely is what explains the clinical difference in what we see between children and adults with papillary carcinoma. Now moving on to the treatment of thyroid cancer. Again, we all understand this is a team sport. There's lots of different experts that need to take care of these children. So, hopefully children with diagnosed with PTC find a multidisciplinary team that can address all of these issues for them. I'm not going to say much about the diagnosis of PTC, except to state that FNA under ultrasound guidance is really the gold standard for diagnosis, and we don't favor excisional biopsies of abnormal lymph nodes. So this is really similar to adults, the best approach to making the diagnosis. The use of molecular markers in a diagnostic sample is certainly a topic for another lecture. And certainly we're learning more about how that might play a role in pediatric nodule evaluation. As you may know, in 2015, the American Thyroid Association came out with an inaugural set of guidelines that tried to codify kind of our approach to how we treat pediatric papillary thyroid carcinoma. Obviously, this is not a perfect document and more of a recommendation for optimal care. And currently, the ATA is a task force has been put together to revise these guidelines. So there will be a revision, hopefully, within the next 1 to 2 years. This is a high-level overview of how we treat pediatric PTC. Of course, surgery is the most important treatment and typically involves a total thyroidectomy plus or minus lymph node dissection. And highly important that this surgery be done by a very experienced thyroid cancer surgeon. This is typically a surgeon who's not specifically a pediatric trained surgeon, but more of an adult head and neck or endocrine surgeon who does a lot of thyroid cancer. So very important to get these children to a high volume surgeon for better outcomes. It used to be that we gave every child with papillary carcinoma treatment with radioactive iodine, and now it's possible. We're no longer treating every child with radioactive iodine. And finally, after a treatment is complete, we give levothyroxine to cause some degree of TSH suppression, depending on the extent of disease, and we monitor the patients long-term, primarily with neck ultrasonography and thyroglobulin antibody assessment. Again, just to reiterate, treatment at high volume centers is preferred for these patients. The approach to surgery is not very different than adults. And again, most children, because they have a higher rate of lymph node metastasis, and also I didn't show this data, but have a higher rate of multifocal disease, total thyroidectomy is performed for most. If disease is identified in the lateral necks, then a lateral neck dissection would be indicated. And of course, if you do a lateral neck dissection, it's also advised you do a central neck dissection. What remains controversial, I think, in all thyroid cancer management is the role of a prophylactic central neck dissection in a patient. So our approach has been that in a child, particularly with a tumor over 1 centimeter in size, that we consider at least an ipsilateral prophylactic central neck dissection, because there is a higher risk there will likely be microscopic lymph node disease there. There is accumulating data, however, that less than total thyroidectomy may also be an appropriate approach in children. And as we think of children with PTC and this long-term excellent prognosis, I think the more we can do to improve long-term quality of life is important. These are just two more recent studies that try to look at this in terms of the possibility of doing less than total thyroidectomy and specifically a lobectomy in children. And so now many of us actually in our practices with a unifocal tumor, no obvious lymph node disease, we will typically recommend starting with a lobectomy and possibly with an ipsilateral central neck dissection. The ATA guidelines were the first to try to put pediatric PTC patients into risk categories depending on their pathology. We all recognize this is a very imperfect system and not very clear, particularly in terms of the word extensive. But what this was an initial attempt to do was to try to categorize the children postoperatively so that we can know how best to stage them. Again, in the past, every child would go to radioactive iodine. And so this was a first attempt to try to identify the lowest risk patients who may not benefit from radioactive iodine therapy and can just be monitored with TG and ultrasound as well. And for more intermediate and high-risk patients, then additional diagnostic imaging with a diagnostic thyroid scan and possible treatment with radioactive iodine is recommended. Now, sorry about that. Now, I should state that there are other national guidelines that actually believe that radioactive iodine should be given to most pediatric thyroid cancer patients. So Polish guidelines and more recently the Dutch guidelines. So there is a differing opinion throughout the world on this. This is my personal approach as to how I handle these patients is, after surgery, we look at their risk categories. The low risk patients we monitor without further evaluation, or at least in terms of nuclear medicine evaluation. For intermediate and high risk patients, I do like to get a diagnostic scan as well as a stimulated thyroglobulin. And then basically based on that data or a new dynamic risk stratification, postoperative restaging, then the decision to treat is made based upon this new data. And I don't have time to go through this, but the slide is available for your use. What's important to recognize and what we're increasingly recognize is that for children with distant metastases from papillary thyroid carcinoma, that it's actually very hard to achieve cure. Now, some older studies showed higher cure rates in this setting, as you can see here from 2013. But I think with the advent of ultrasensitive thyroglobulin assays, the advent of more sensitive diagnostic testing, we are learning that a lot of patients still have persistent disease despite previous therapies with radioactive iodine. Our experience is here on the right, where we saw only 7% of our patients with a complete response. Again, this is a very biased study because we're a referral center, but I was relieved to see that Dr. Al-Zahrani's study from Saudi Arabia showed actually very similar outcomes. So we have to keep in mind that radioactive iodine is not necessarily going to cure all cases of pediatric thyroid cancer. So we use it when we feel the patient would benefit, when we feel they have, a chance of cure. But after time, we should recognize that we shouldn't keep giving radioactive iodine and that we maybe have a more thoughtful approach over the first few years of follow-up instead of aggressively treating like we did in the past. With the last few slides, I'd like to talk about where the future is. Where are we at in terms of treating advanced disease or thinking about this disease differently? Let's specifically focus on stage 2 disease in children. And this again is MD Anderson data, where in 69 patients who had comprehensive molecular testing, you can see here that most of these patients actually have a RET fusion, followed by INTRAC 1 and 3 fusions, and then finally the BRAF V600E mutation, and 7% are unknown. This on the right is just to contrast a study looking at adults with stage 4 PTC, so kind of an equivalent. And what you see, the difference here again is higher BRAF mutations, fewer fusions, and actually we now see RAS mutations, which is not something that at least has been commonly reported in pediatric PTC that has metastasized. The good news is that in the pediatric age, over 90% have actionable mutations. So we now have all these therapies that could target these oncogenic drivers. This is just to highlight all that's available, at least in the United States, to treat advanced thyroid cancer, and this is more of the pediatric context. We have, the multi-kinase inhibitors, and we now have selective kinase inhibitors that target TRAC fusions, RET fusions, and more recently, cabozantinib was approved for ages 12 and older to treat in the second line as a second-line therapy. There's been a lot of interest in using these inhibitors to redifferentiate tumors that are no longer concentrating iodine. This is a nice case study from the Korean paper in 2021. This is a patient with a RET-fused thyroid cancer who does not have RAI-avid disease and was placed on a RET inhibitor on a clinical trial. And you can see over time, there was a progressive rise in iodine uptake. I want to share a couple of examples from MD Anderson, where we're now exploring more of the role of this neoadjuvant approach in the treatment of young people with thyroid cancer. This is a young woman here with a very locally advanced RET fusion positive papillary thyroid carcinoma on whom was enrolled on a clinical trial with a selective RET inhibitor. And you can see she's had a significant clinical response. And so, you know, we're trying to learn, is there value in terms of shrinking these tumors, bulky tumors preoperatively, in terms of decreased risk of hypoparathyroidism and recurrent laryngeal nerve injury. And most recently, we published a case experience of using an NTRK inhibitor prior to the first dose of radioactive iodine. As you can see here, there was some uptake in lung metastasis. The NTRK inhibitor was given more to shrink the tumor size, thinking that a smaller tumor would respond better, but to our surprise, it also significantly redifferentiated the tumor, which allowed good treatment with a high dose radioactive iodine and an excellent response at 1 year of follow-up. So here's our current paradigm of how we treat these patients, and our future paradigm might actually start to involve more of these selective kinase inhibitor therapies, either before surgery or even before the first dose of radioactive iodine. In summary, hopefully I've shown you that PTC in children presents with more advanced disease, but is less aggressive, and this is primarily due to differences in the molecular biology. Pediatric PTC is best treated at high volume centers. TSH suppression and radioactive iodine still remain frontline therapies for metastatic PTC, but appropriately, the role of radioactive iodine is diminishing because it's now being recognized that we can't cure everyone with it, and that some patients may not need it to begin with. And finally, oncogenic fusions are prevalent in pediatric PTC, and there are now new targeted therapies that may start to change the treatment paradigm. With that, I'd like to give you my sincere thanks. Thank you for allowing me to participate in this inaugural meeting, and hopefully someday we can meet in person. Thank you again.
Thank you, Professor Razabak, about updating us about the management of papillary thyroid carcinoma in pediatrics. And our next talk will be given by Dr. Walid Qabalan about Graves' disease in the pediatric population. Dr. Qabalan is a consultant pediatric endocrinologist and the chairperson of the Department of Pediatrics at Tawam Hospital. He is also an adjunct associate professor at the UAE University in Al Ain in the United Arab Emirates. He previously held the positions of interim chief medical officer and acting chief quality officer at Tawam Hospital and assistant professor of pediatric endocrinology and metabolism at Baylor College of Medicine in Texas Children's Hospital in Houston, Texas. Dr. Qabalan he's certified by the American Board of Pediatrics in Pediatric Endocrinology, and his research interests include diabetes, growth disorders, and calcium and bone metabolism, as well as thyroid disorders. And he had been known for his tremendous work in pediatric endocrinology in the area. He had established the Emirates Pediatric Endocrinology Club, and he is an active participant in several local and regional endocrinology groups and associations. So without further ado, Dr. Walid, the floor is yours.
I am Walid Kaplan, a consultant pediatric endocrinologist at Tawam Hospital. I would like to thank the committee for their invitation to give this lecture. And my topic today is Graves' disease in children. I am going to go over some terminology and epidemiology information and then explain to you the diagnostic approach and the treatment options for Graves' disease in children. I'm going to use information from the recently published NICE guidelines of the European Thyroid Association. about Graves' disease in children, and it has most of the information I'm presenting today. So let's start with some definitions and introduction information. Hyperthyroidism is the status of increased thyroxine synthesis by thyroid gland, and thyroid toxicosis is the clinical condition that results from this increased thyroid hormone status. Most of the cases of hyperthyroidism in children are of primary origin, and Graves' disease is the most common type of those. And subclinical hyperthyroidism, which is more known identity in adults, has been listed sometimes in children. It has a biochemical definition with low or suppressed TSH and normal free T3 or thyroxine level in general, and no clinical symptoms. Graves' disease, an autoimmune disorder. It is caused by the increased TSH receptor antibody, which has multiple names: thyroid stimulating immunoglobulin, thyroid binding inhibitory immunoglobulin, and other names. They all indicate to the same antibodies that stimulate the thyroid gland, similar to what the TSH does. It is not very common condition, as you can see in these figures from different countries. This is not a common disease in children, and it is more common in girls than in boys, like the case in most of the other thyroid conditions. The clinical presentation is not the same between patients. They will have different scope of features and different levels of intensity. Most of the patients will present with thyromegaly of different degrees, which is known to be symmetrical with no nodules. And then there is a list of symptoms between fatigue, palpitation, fine tremors, heat intolerance and increased sweating, weight loss, and ophthalmopathy. Patients will not have all these features, but the more features they have, then the more clinical suspicions of Graves we will have. In addition to that, there are behavioral issues that are usually recognized by the school teacher, such as decreased attention span and worsening school performance. But sometimes parents also report increased anxiety and disturbed sleep pattern. Last but not least, some cases will present with accelerated linear growth and advanced bone age. As I said, you're not going to see all these symptoms, but the ones that are bolded are more commonly to be seen in children. So what is your role when you see a case of suspected Graves' disease? Means a child with goiter, cardiovascular symptoms, heat intolerance, tremors, and other symptoms. Now you suspect Graves' disease. How can you confirm the diagnosis? First, you have to do a lab evaluation, and the lab evaluation simply includes thyroid function test. But in the case of Graves' disease, we must do the free T3 because it correlates more with the severity of Graves' disease, and it is actually more elevated than free T4. So you should do, beside TSH and free T4, free T3. In addition to that, we have to measure the TSH receptor antibody. As I said, they are the engine behind all the symptoms and abnormalities. So we should document that they are elevated. And then anti-thyroid antibodies are not uncommon to be increased in Graves' disease, but we do it because sometimes Hashimoto thyroiditis might present with a thyrotoxicosis-like picture, but it will be a transient phase of Hashimoto, and in this case, the antibodies will be extremely high, and the TSH receptor antibody will not be elevated. Once you do the lab evaluation, we move to the second diagnostic step, which is the thyroid scan. And the thyroid scan will actually be very specific of Graves' disease, which shows a homogeneous and diffuse increased uptake of the scan used in your facility, which will confirm the diagnosis. So basically, if you have the typical thyroid function findings of suppressed TSH, elevated free T4 and elevated free T3, that's on one side. There is an increased level of TSH receptor antibodies, that's on the other side. And then the thyroid scan is consistent with Graves. You already made a diagnosis. This is Graves' disease. The reason why we do the scan also because you need to make sure that you're not dealing with a toxic nodule or autonomous nodule, in which there will be only a focal area of hyperactivity, and that is not Graves' disease, and that can be treated with surgery. So it should be differentiated from Graves' disease, and the best way to do that is doing the thyroid scale. So what are the treatment options? You see the patients, you had your clinical suspicions, you do the diagnostic workup, you make a diagnosis. How can you treat those patients? First of all, let me emphasize that it is important that those patients not to be left for long without any clinical attention. Treatment should be urgent and immediate as recommended by the guidelines because of the cardiovascular, neurological, and behavioral changes, and it is unsafe to keep the child suffering of these symptoms for long before we start the treatment. The treatment has 3 arms or 3 components. We start with medications, and then we end up, if medications don't work, with either radioactive iodine or with surgery. So let's start with the medication, which is basically a first line of treatment, but I want to emphasize that the anti-thyroid drugs, which is basically the medication we use, are not curing the condition. They're only opposing the effect of the TSH receptor antibody. So anti-thyroid drugs will suppress or inhibit the thyroid hormone synthesis, and the TSH receptor antibody will stimulate thyroid hormone synthesis. So we have an opponent effect, and we try to titrate the dose of the anti-thyroid drugs to overcome the stimulating effect of the TSH receptor antibodies. So we're kind of masking or opposing the symptoms, but we're not curing it, because once we stop the medications, if the antibodies are still there, the condition will relapse just immediately. So the 2 common medications are the carbimazole and methimazole. In the Gulf region, we only have the carbimazole. The methimazole is the active ingredient or metabolite of carbimazole. 1 gram or 1 milligram of carbimazole is equivalent to about 0.8 milligram of methimazole if you want to do the dose conversion. BTU is known to be one of the anti-thyroid drugs, but it is strongly recommended to be avoided in children because of its harmful effect on the liver. The starting dose is according to the weight, somewhere between 0.3 to 0.7. Most of the time we need the higher dose in the beginning to produce the full inhibitory effect. And then once we achieve euthyroid status, then the dose can be reduced gradually to the maintenance dose, which is expected to be somewhere between 1/2 to 1/3 or 1/3 to 1/2 of the starting dose. We have to do a baseline CBC and liver function test to monitor the side effects of these drugs that I will mention later on. Beta blocker is another class of medications that we need to use in those patients who have tachycardia. So their use is only when we document tachycardia. We can use them in any age group from neonate onward, and the indication should be as needed. So if the patient has tachycardia, the medicine can be given. Once the tachycardia is resolved or gone, then the medicine should be on hold. So what is the outcome of the medication treatment? We expect that within 4 to 6 weeks that the free T4 and free T3 will normalize. It will take much longer than that for the TSH, several months, sometimes even more than 6 months to normalize. So we should focus on following the free T4, free T3 in the initial phase, and then TSH later on. Remission rate is not very high, unfortunately, expected to be 20 to 30% after 2 full years of treatment. Longer duration will lead to a longer remission rate, but I can tell you that even after 5 years of treatment, the remission rate stays below 50%. And then the relapse rate is basically variable, as I said, according to the TSH receptor antibody status. So we measure those antibodies at baseline, and we give the course of treatment, say, for 2 years, and we repeat the level. If the level is still as high or even higher, then the relapse is definite. And this is probably going to be the time when you need to discuss with the family the other options of treatment, if possible, for patient's age. So in this figure, I'm showing you the relationship between the duration of treatment on the x-axis and the percentage of remission on the y-axis. The size of the bubble correlates with the number of patients treated. And you can see that there's almost a linear relationship between the duration and the percentage of remission. But once again, you can see even with the study, and this is a prospective study, of even almost 10 years of treatment, the remission rate did not reach 80%. So what are the side effects? Side effects are usually seen in the first 3 months of treatment. And fortunately, most of the side effects are mild and transient, and they present in a form of skin rash and itching. There are a few more serious side effects, but they're not reported commonly. And those are a granulocytosis on one side and the hepatitis or disrupted liver function, or sometimes even hepatotoxicity on the other extreme. Once again, those are rare, but they are very serious, and they will have to basically lead to stopping the medications and look for another form of treatment. So we talked about the medications. The second line of treatment is the radioactive iodine. And the radioactive iodine is considered a definitive treatment because it will basically control the condition permanently. It is not curing it, though. I would like to emphasize this again. Let me give you an example. A woman has Graves' disease, treated with radioactive iodine, and then several years later, she gets pregnant. The TSH receptor antibodies are still in her circulation, and they will cross the placenta and they will induce neonatal Graves' disease. So we did not clear the antibodies from the circulations. We simply ablated thyroid gland, so there is no target tissue for these immunoglobulin to affect. So the patients will become hypothyroid at the end of the treatment, and we should give them thyroxine replacement to maintain a euthyroid status on those patients. It is contraindicated treatment in young children below the age of 5 for safety reason. It is also contraindicated in pregnant and nursing mothers. It might be considered before surgery between the age of 5 and 10 if medications either do not work or are not tolerated, and the patient between the age of 5 and 10, then the radioactive iodine can be discussed against surgery, and then the treating team should decide which one is more safe to consider. So the indication of radioactive iodine, number one, if there is serious adverse effect of these drugs, such as the one I have listed. If there is relapse after an adequate duration of treatment, and I put here 3 to 5 days because I believe this is fairly long time of treatment, and many families will not be patient to wait this long. So if your patient is treated that long and then you repeat the TSH receptor antibodies and they're still elevated, then I think it's time to consider alternative treatments such as radioactive iodine. Patients who are non-compliant in taking the medications or monitoring side effects should also be switched to an alternative treatment than the drugs. And last thing, if the family decide on their own that their child who's older than 10 wants to receive the radioactive iodine, I think it is acceptable that you endorse their decision and switch the patient from anti-thyroid drugs to radioactive iodine, or even give it from first line if that's the family request and they have a previous member who was treated and they want to pursue the same treatment in the second child who is older than 10. So the limitation of the ablation is basically, number one, the ophthalmopathy or the exophthalmos. It is known that patients who have these findings before the treatment will get worse when they get the treatment. So this will be a scenario where surgery might be even favorable to radioactive iodine if the ophthalmopathy is very clear or severe. Patients who are younger than 5, as I said, cannot take radioactive iodine, and patients between 5 and 10 can take it, but again, it should be weighted against the surgery and decide which one is a better option. And those who have large goiter, there is always concern that they might go into uncontrolled hyperthyroidism with the ablation. So it is recommended that they get treated with 2 to 3 months with the anti-thyroid drug to control the case even partially, and then receive the radioactive iodine. Few caveats about the treatments. The anti-thyroid medications, as I said, should be given for large goiter. Medication should be stopped 3 to 7 days before giving the radioactive iodine. And then the follow-up should be done in about 4 to 6 weeks. As I said before, you need to focus on the free T4 and free T3. You have to anticipate that TSH takes longer to normalize than the thyroid function test. So having normal free T4, normal free T3, or even improving ones, while TSH is suppressed, does not indicate that the treatment did not work. Just be more patient. And then if patients continue to be hyperthyroid 12 months after the dose of radioactive iodine, this is a sign that the dose that was given was inadequate and patients should take a second course. This is unlikely to happen if the nuclear medicine physician is expert in this field. The third option of treatment is surgery, and surgery again should be considered when the anti-thyroid drugs fails in younger ages because the radioactive iodine cannot be given. It is a definitive treatment. It also be considered when there is obstructive symptoms and we need to have an immediate relief of the hyperthyroid, either clinical symptoms or compressing symptoms, then surgery becomes indicated. There is basically no clear one absolute contraindications. However, similar to the radioactive iodine, if there is severe hyperthyroidism, it is recommended that we give medications for a couple months and then surgery to be done to avoid uncontrolled hyperthyroidism. The advantages of the surgery, it gives immediate relief of symptoms and there is no relapse because we're removing the thyroid gland. The cons on the other side, risk of general anesthesia, risk of infection and bleeding, and if the surgeon is not expert, there is always risk of hypoparathyroidism by removing all the parathyroid glands. What about Graves' disease and cancer? There is data in adult patients that those who have Graves' disease are more likely to have thyroid cancer. And there's another set of data that showed that thyroid cancer in patients who had Graves' disease in the past is more aggressive than patients who did not have Graves' disease. However, there is no such information in children, but to be on the safe side, it is recommended that if a child has Graves' disease and then found to have thyroid nodule, to be on the safe side, we should do FNA to ensure a safe nodule. Prognosis of Graves' disease in general is not bad. However, you have to keep in mind that the euthyroid status is not achieved very commonly. As I said, with the anti-thyroid drug treatment for several years, the remission rate is in the range of 50 to 60 when we give the treatment for more than 5 or 6 years, but only 20 to 30% for 2 years of treatment. The radioactive iodine and the surgery will give us a definite treatment, but then the patient should take thyroxine replacement to maintain euthyroid status. There is data in adult patient that Hashimoto thyroiditis is seen more commonly, so we need to monitor our patient for this and measure thyroid antibodies. And there's another data showing there is lower quality of life in survivors of Graves' disease. So in summary, Graves' disease is uncommon in children, but it does require immediate attention. The anti-thyroid drugs can be considered as the first line of treatment. However, the remission rate is low. Radioactive iodine and surgery are definitive treatment, but permanent thyroid replacement will be needed to maintain euthyroid status. Thank you so much. I'll be happy to take any question.
Dr. Walid, for this update on Graves' disease in children. I would like to thank all the speakers for these excellent presentations. And yes. And we can start the Q&A session. Okay, well, we get some questions from the audience. Let me start by asking Dr. Rasha, if she's still online with us. Dr. Rasha? I think Dr. Rasha is offline. Okay, so let me start with asking Professor Wagesbach. We have a question here from our audience. refractory to iodine in kids happens after a while, or right? Yes. The refractory period happens to iodine therapy in children happens after a while, or is it's right at the time of diagnosis?
Yes, so thank you. That's a good question. It could be either, actually. So, you can appreciate different patterns of RAI uptake in children with distant mets. Again, I think we're talking mostly kids with distant metastases. So there may be some. So our standard is we get a diagnostic thyroid scan. I'm not quite sure what everyone does at their institutions, but we usually get a diagnostic scan. So there'll be the kid who has the very intense uptake at the beginning on just a diagnostic scan with the trace dose of I-123 or I-131. So those are unlikely to become RAI refractory, although they could. Then we have the kind of the subset that have a negative diagnostic scan, and then you give them a dose of I-131, and then on the post-treatment scan, it shows much more intense uptake. And those, in my experience, could potentially become RAI refractory, meaning like down the road, if you give them more treatment, they might not have that same uptake on the post-treatment scan. And then there are those rare cases, but they do happen. And I've seen them, of course, with BRAF mutated tumors, because we know that BRAF mutated tumors decrease RAI uptake in these cancers. But I've also seen it in both RET and NTRK fusion positive cancers, where traditionally I think there's good iodine uptake, but in these children, what you see is no uptake on the diagnostic scan. And then on the post-treatment scan, you see no uptake on the post-treatment scan. So it's a long-winded answer to a good question.
Thank you. Thank you, Professor. And can I ask you, Professor, I can imagine like management of children with papillary thyroid cancer is quite a tight kind of operation. Now, can you tell us about your experience of how did the COVID-19 pandemic, with all its restrictions, lockdown, and the stress on all of these families had changed, if there is a change in your practice or management of these children? Mind you that these children are on a lot of psychological stress. You have a lot of procedures that you need to do and so on. So how did the COVID pandemic change such operation of management of such a condition? And if it changed, what would you advise, or what have you learned, or what you advise in terms for preparation for the next pandemic, if hopefully no pandemic happens? But I always think of like we have to learn of what happened, and there is a lot, like the COVID-19 had placed a lot of challenges in management of a lot of conditions. So I would like to hear about your experience, if any, during the COVID-19 pandemic with regards to this condition and management.
Yeah, no, thank you. So, the main way it impacted us is that, we shut down all elective surgeries for a while, and starting like in April 2020. But then, we decided, well, if you have a patient with a cancer diagnosis, is that truly elective or not? So we rapidly started to offer operations, particularly for patients with more advanced disease. But it didn't really impact us so much, other than just the rules and regulations of, what was very hard is they really strictly limited the visitors. And at least for the children, they still allowed one parent to accompany the child, but that was a huge thing. Like you said, the families are stressed, the parents are stressed, so we had to get more people on the phone. And, that's always a little awkward, to be talking to multiple people on the phone, not quite sure who's there or not. And I think a good thing that for us that's come out of the pandemic is the advent of telemedicine. Yes. Because before we had no option of meeting our patients on Zoom like this. And so that's really been good, because, a lot of our patients, travel long distances. You may just need to review their thyroid function studies or review their pathology, which may not require an in-person visit. So, to leave on a positive note, I think that's been the one good outcome, at least that we've seen. I don't know, are you guys doing are you able to do these telemedicine visits?
Yes, I agree. We have learned a lot. And I think also Dr. Waleed will agree with me as well. We have it has been a stressful pandemic, but it was such a learning experience for all of us healthcare professionals. Yes, and the use of telemedicine, it's been available previously, but and during the pandemic, it was forced on us, and we have learned how we still continue doing this. So I think it was an excellent learning experience for all healthcare providers around the world.
Absolutely.
Yes. Now, a question. Can I have a question? Let me ask Dr. Waleed. It was lovely hearing your talk, Dr. Waleed. And I would like to ask you about your practice with regards to children who have Graves' disease and they're on antithyroid medications. What is your practice when they present, for example, with a febrile illness or get admitted with febrile illness? Mind you that these antithyroid medications might have side effects. So what is your practice? One of these children come with a febrile illness or get admitted to the hospital with a febrile illness or investigation for fever.
Thank you, Daria. Good seeing you. Good seeing you, Steve, as well. Basically, agranulocytosis is one of the very rare but serious side effects. So a standard CBC, if it shows that the ANC is normal, I would approach those children like I approach any other child, even they're on the antithyroid drugs. However, if the neutrophil count is low, then we have to consider actually stopping the medications and then assess the children for the cause of the fever and then consider alternative treatment. Yes. But as I say, this is rarely to happen. Luckily, it's not something we see commonly.
Yes, agreed. Now, Dr. Waleed, have you seen, again, I'm quite interested about the COVID-19 pandemic and lessons to be learned. So in your practice, had the COVID-19 changed the spectrum or the presentation of children with Graves' disease during the pandemic, especially that we have some neuropsychiatric and developmental issues these children face? Now, has the COVID-19 pandemic in your practice or you come across literature that the spectrum of the presentation of such disease has changed during the pandemic? Are we facing more neuropsychiatric or developmental issues during the pandemic because of in these children with Graves' disease?
Well, I wish I could answer these questions. Because of the rate of Graves' disease, as I have shown, we don't see many cases frequently. So probably I don't even remember diagnosing new cases during the peak season of COVID. However, the children whom we have been following, we have not seen a change in their course during the COVID, but those are children who have not been affected by COVID. Mm-hmm. But it's, I think, we have been seeing a wide spectrum of interaction between COVID-19 and many other conditions. I would not be surprised to see some changes in Graves, but I haven't seen that in my practice during the period of year and a half.
Yes, agreed. Thank you, Dr. Waleed. We have a question here in the question box for Dr. Stephen. I'm not sure it was typed in a way that I can't understand it, but I hope it will make sense for you, Professor. For kids with medullary, prophylactic central is recommended? You can see it in the question box. Medullary carcinoma, yeah. So for kids with
medullary carcinoma? Oh, yes. There we go. Okay.
Yes, you can see it. Yes. Prophylactic central is recommended? Question mark.
I believe that they're asking about the neck dissection, probably.
Yes, yes. I think I understand. So yes, if most kids, so today most kids with medullary cancer are gonna likely have very small tumors that you've picked up through prospective screening because they've been genetically identified. So in someone with clinical MTC, they're picked up because of thyroid nodule, then, for sure, the standard of care is a central neck dissection. Now, in someone who's kind of more, you're catching through screening or catching earlier, then it can kind of depend on the size of any primary tumor as well as the degree of calcitonin elevation. So generally, if a calcitonin is less than 40 and there is just a microscopic focus of tumor in someone with MEN2A, then I would probably not do a prophylactic central. And of course, anyone getting a prophylactic thyroidectomy, I would not do a prophylactic central. In an MEN2B patient, again, depends on the clinical presentation, but more likely to consider that. I'm not sure if I've answered your question, but hopefully I did.
Yes, I think we have all the questions here answered. So that concludes our Q&A session. I would like to thank the speakers, Dr. Rasha, Professor Wagisbach, and Dr. Qabala for such outstanding talks on pediatric thyroid issues. And hopefully we'll see you in the future in future talks and meetings. Thank you very much. It was a pleasure.
Thank you. Thank you all.
Thank you, guys. Have a good evening.
Bye, Steve.
Bye, Waleed. Good
Bye.
seeing you.
Take care, everyone.